The fluoride ion is the most effective karyostatic agent in the history of dentistry, yet the exact mechanics of how it protects the porous surface of human enamel have been a subject of evolving debate. In the 1940s, dental researchers identified a direct correlation between naturally fluoridated water supplies and significantly lower rates of dental caries in those populations. Public health officials responded by engineering infrastructure projects to artificially add fluoride compounds to municipal water supplies on an industrial scale. The foundational logic behind these early campaigns was that ingested fluoride traveled through the bloodstream to be permanently embedded into the lattice of developing teeth before eruption. Modern evidence-based dentistry has since moved away from this purely pre-eruptive model. Research has observed that fluoride's primary protective effect occurs after the tooth has entered the oral cavity through direct and frequent surface contact. This delivery relies not on the bloodstream, but on the continuous bathing of erupted teeth and ambient saliva and plaque fluid. Understanding the distinction between these two pathways, systemic and topical, is the first step in accurately calculating patient risk and preventing overexposure. Human enamel is primarily constructed from a crystalline mineral called hydroxyapatite. Hydroxyapatite has a specific architectural vulnerability. It begins to dissolve when the local environment reaches a critical pH of 5.5. This 3D vector model shows the hydroxyapatite equation reacting with an incoming fluoride ion. Because of its size and electronegativity, the fluoride ion physically breaks the existing bond and displaces the hydroxyl ion from the lattice. This atomic substitution creates a denser crystalline structure, fluoropatite. This dissolution curve graph maps the precise effect of that substitution. The critical pH required to dissolve the new structure drops from 5.5 down to 4.5. Because pH is measured on a logarithmic scale, a 1.0 drop means the fluoroapatite surface can withstand 10 times more bacterial acid before dissolving. Fluoride also exerts a secondary action by serving as a remineralization catalyst within the plaque fluid. When ambient calcium and phosphate ions are present in the saliva, fluoride pulls them back into early, non-cavitated white spot lesions to repair microscopic damage. Fluoride physically upgrades the tooth's hardware to survive a harsher environment, but structural hardening alone doesn't stop the source of the acid. To stop the acid production, the intervention must move off the surface of the enamel and enter the interior of the karyogenic plaque biome. A bare fluoride ion has a negative charge, which prevents it from independently crossing the lipid bilayer of a bacterial cell wall. This schematic of a Streptococcus mutans cell wall shows how the local environment provides a mechanism for entry. When bacteria ferment sugar and the pH drops, the acidic environment forces the fluoride ion to bond with free hydrogen, forming hydrogen fluoride. Because hydrogen fluoride is a neutrally charged molecule, it easily diffuses directly across the bacterial membrane. Once inside the higher pH interior of the cell, the molecule dissociates, splitting back into separate hydrogen and fluoride ions. This sudden influx of trapped hydrogen ions causes rapid intracellular acidification, lowering the internal pH of the cell. Simultaneously, the newly freed fluoride ion navigates through the cell and binds directly to the enzyme enolase. Enolase is a critical component of the bacterial glycolytic pathway. Inhibiting it halts the bacteria's ability to metabolize carbohydrates into acid. The fluoride ion then delivers a secondary disruption to the cell's proton-extruding ATPase, interfering with the bacteria's mechanism for pumping out acid. Fluoride operates as a targeted biochemical weapon, leveraging the bacteria's own acidic waste to infiltrate and shut down its metabolic engine. This logarithmic bar chart compares the immense variance in parts per million concentrations across different clinical fluoride vehicles. At the low end of the spectrum, community water fluoridation provides a highly diluted baseline of 0.7 parts per million. Standard home care over-the-counter toothpaste contains between 1,000 and 1,500 ppm, requiring smear or pea-sized dosing for pediatric patients to prevent ingestion. Moving into the operatory, the professional standard is 5% sodium fluoride varnish at 22,600 ppm. The resin base ensures prolonged topical contact with a low risk of ingestion. 1.23% acidulated phosphate fluoride, or APF gel, delivers 12,300 ppm via a tray system. However, APF carries a specific contraindication. Its low pH and hydrofluoric acid content will etch and damage porcelain or composite restorations. 8% stannous fluoride offers antimicrobial action against plaque, but the tin ion frequently leaves a brownish-black stain on the teeth. The apex of the clinical concentration scale is 38% silver diamine fluoride, reaching a massive 44,800 ppm. SDF is used for active, non-invasive caries arrest. The high concentration stops the decay, but the silver ions undergo an oxidation reaction that turns the carious lesion black. Selecting a delivery vehicle requires matching the chemical concentration to the severity of the patient's active disease state. The therapeutic index for fluoride is narrow. The line between optimal prevention and systemic toxicity requires precise calculation. Chronic toxicity, known as dental fluorosis, can only occur during the active phase of enamel formation, between birth and 8 years of age. Excessive systemic fluoride disrupts normal ameloblast function during this window, resulting in enamel matrices characterized by subsurface porosity and chalky white opacities. Over decades, exposure to high-concentration endemic water sources leads to skeletal